Low back pain, common questions and answers. Low back pain patient will have no cause for the back pain in about 85% of the time, and they will recover in 6 weeks in about 90% of the time. Here is a patient that has low back pain for 2 weeks. What is the treatment? No MRI and no surgery. You just do conservative treatment. Here is a patient that had low back pain for 2 days and the pain is severe. What is the treatment? Return to work as guided by the symptoms. No MRIs. Here is another patient that has low back pain for 8 weeks and is not getting better. What is the indication for surgery? Severe refractory radicular pain. Here is a patient with chronic low back pain for 6 months and no rehab. What is the chance of that patient going back to work? 50%. Here is a case of buttock pain or low back pain. When the pain is posterior, the patient may think it is the hip that's causing the pain, but it can be the hip, it can be the sacroiliac joint, and it also can be the lower spine. The sacroiliac joint is a challenging diagnostic and treatment entity. The sacroiliac joint pathology symptoms overlap with spine symptoms and hip symptoms. Injection of the sacroiliac joint, probably the method to diagnose pain coming from the SI joint versus the other two entities. Here is a question about pain coming from the SI joint or from the hip or from the spine. And the answer is inject the SI joint. No MRI and no EMG and nerve studies, and don't inject the hip. The disc is made of 2 parts, nucleus pulposus and annulus fibrosus. The nucleus pulposus has a lot of type 2 collagen. It is the soft gelatinous material that herniates. The location of the disc herniation can be posterolateral. In case of L4, L5, we'll get L5 nerve root, or foraminal, which is rare. In case of L4, L5, it will get L4 nerve root. And these are the 2 types. Or it can be central. We'll wipe out a lot of nerve roots, causing coda equina, bladder and bowel symptoms. It's an emergency. Emergency MRI and urgent surgery. Which disc herniation is dangerous? It's the central disc that can cause coda equina. Do you know the answer? This is a patient that has central disc herniation, large one with perineal numbness. It's probably coda equina. The patient probably has bladder and bowel symptoms. Trendelenburg gait is very popular in examinations. The gluteus medius is the abductor muscle of the hip. Deficiency of this muscle will cause Trendelenburg gait. The superior gluteal nerve is important. Injury of that nerve will cause Trendelenburg gait. The L5 nerve root, if it is injured, will cause Trendelenburg gait. So how do you get this gait in association with which disc herniation? An ipsilateral paracentral disc herniation at L4, L5, because that will get the L5 nerve root. They answered it as L4, L5 far lateral. That far lateral one where 50% answered that was the wrong answer, because that will get you L4 nerve root. Talking about L5, L5 nerve root control the extension of the big toe, control the sensation at the top of the foot. Here there is a foraminal disc herniation at L4, L5 will get L4 nerve root. That will be decreased patellar tendon reflex. A posterolateral disc herniation at L5S1 will get the S1 nerve root and will have decreased sensation at the lateral aspect of the foot. Sciatica is a self-diagnosed condition and usually improves with time. It got a component of nerve pain, sharp shooting pain like an electric shock that radiates to the leg and the foot. There might be burning, tingling pain and some numbness. Sitting aggravates the pain because it stretches the sciatic nerve. When the patient with sciatica comes to us with an MRI that had disc herniation, we immediately think the disc herniation is the cause of the symptoms, but there might be other causes for the sciatica. That's why we have to examine the patient carefully. The best examination for lumbar disc herniation is a straight leg raising sign. It is the tension sign. You must correlate the clinical exam with the X-ray findings and the MRI findings, because it can be a hip, or it can be a spine problem, or it can be other causes for sciatica. When you have a patient with low back pain, look for other conditions such as hip problems, metastatic tumors, infection, vascular condition. Always examine the pulses. If you have infection of the spine, it will affect the intervertebral disc space. If you have a tumor, there might be a loss of the pedicle, and it will give us the wink sign. The spine is the most common location for metastatic tumors. It usually occurs in the vertebral body, then it goes to the pedicle. So let's take the difficult scenarios that we may face. Here is a patient with low back pain and got gait disturbances and hyperreflexia. So he got an upper motor neuron lesion. So it's not coming from the lower back. It's probably coming from the cervical spine. So you need to get an MRI of the cervical spine. In lumbar stenosis, history is the key in making the diagnosis. The patient may have leg pain, back pain, buttock pain, weakness, cramps, and the heavy sensation. And we call that neurogenic claudication. Neurological exam is normal in about 50% of the patients. And you can see here the shopping cart sign is positive. The patient is comfortable when they lean forward and bend their back. There are some questions. The patient will have difficulty in walking in the mall because they got to straighten their back. In differentiating vascular claudication from spinal stenosis or neurogenic claudication, the patient with a spinal stenosis will be able to ride a stationary bike, as you can see here, because in vascular claudication, you can't do that because you have to use the muscles. The muscle doesn't have a lot of oxygen. But in spinal stenosis, what will hurt the spine is extension of the back, not moving the muscles. You got to check the pulses. You got to make sure you don't have other conditions like hip problem, metastatic tumor. Here is a question. Patient have a lumbar stenosis picture. What do you want to evaluate? The peripheral pulses. Another question. Bilateral robotic pain, lumbar stenosis. What are you going to do? Examine the peripheral pulses. You got to examine the pulses because neurogenic claudication and vascular claudication may coexist. Here is a patient that had a spinal operation, and after the surgery, the patient had severe left anterior thigh groin pain. So what is the problem? It is hip arthritis. The hip, the spine, and the sacroiliac joint, they overlap, they coexist. You got to differentiate between them, and you got to know which one is the primary source of pain. Lower spine condition may cause referred pain to the buttock and hip area. In fact, symptoms of the hip and the lower spine condition can overlap and they can coexist, and you got to separate pain from the hip from pain that comes from the spine.